Hello, everybody. Mark Brownstein here from Emerald Medicare. It's so nice to have you on this webinar. There was over 150 people signed up. We are excited. I am excited. My team is excited to present to you a whole host of information that we have to share. Um, this is a season of no others. Again, if you can mute yourself on your end, that would be really helpful. So thank you. But from many perspectives, folks, and I say this humbly, Emerald Medicare is really ahead of the trends. Each year, we do one or two of these updates, and very few other brokers or agencies do that. We have expanded our team to a team of 7. So we are positioned to help everyone, um, current clients, prospects, friends, neighbors, colleagues, with Medicare as we roll through open enrollment, as we roll through the rest of the year, because people turn 65 and retire all year long. So we are at this 12 months a year, and we're proud to do it. We're honored to be trusted. Our goal is to work smarter, to help more people. The industry is going through a tremendous amount of volatility. There's a massive carrier reset that's going on, and there's government regulations that are increasing, and the profitability of insurance companies are going down. It's truly going to take 3 years to reset this industry in Medicare. So we are keeping up with the changes. We are aware of all that we can be aware of, and I continue to research. But we know that clients and seniors are anxious about what is going on in this industry. And so that's why I've put this work together with the help of my wonderful team, to present this webinar today. I have in my tech department, I have Matt Civitano, and supporting us, I have for chats, I have Diane and Kerry, who are available to answer any questions that you might have while we're going through this webinar. We are recording it so that will be available on YouTube in a few days or so. So I will start, and again, excited to be here with you, and thank you so much for taking the time to join. People are shouting with a bullhorn on the top of their rooftops about the issues that people are facing or questions that they have. Everything from the big bill to the Inflation Reduction Act to penalties in Part B and copays, advantage plans. All of these things are important. And we cover them, we talk about them every day. But healthcare is a big financial concern for people. The healthcare costs are a big concern, but so is dental and so is drug. So you can see that it's really a big concern for people and financial planners who I work with. I work with CPAs, I work with case managers and social workers. All of the people that I work with and educate all year long really value the insights, but they also know that the impact on their financial planning future is very much connected to their healthcare and their insurances. So a couple of statistics worth sharing. The average cost of healthcare in America is about 11,000 for every man, woman, and child. $4.5 trillion is spent on healthcare in the United States, eclipsing the gross domestic product of many third world countries. But two important informational pieces: 50% of all medical costs in America are pre-diabetic, insulin care, or medications. Insulin costs have come down a lot, but it's a big cost for the insurance companies. Poverty accounts for about 60% of all healthcare costs in America. The goal is to have them be on, even if it's an Advantage plan or a dual plan, to get them healthcare all through the year so that they reduce the hospitalizations. 63% of people age 65 and over consider healthcare to be their number one concern. Also, most new and existing Medicare enrollees really do worry that they will get this important Medicare decision wrong. And that's why we hope that they will reach out to us for help. So Social Security and Medicare increases over the last 30 years. Social Security people always notate and talk about when there's a nice Social Security increase, but the average over 30 years has only been about 2.3%. On the other hand, Part B premiums have gone up about 5%. This year, Part B premiums are going up 11%. So even at the baseline that has been seen over the last number of years, um, right now, Part B premiums are 185 a month, going up to 206.50. Um, so I'm going to cover some basics and then go into some more detail on some changes. But health insurance is really different for everyone on this phone call. Whether you're approaching age 65 or you're retiring soon or already retired, there's so many options that you have with your current company and with Medicare in general. So it's important to compare your group and retirement coverage to Medicare options. Many people share with me their benefit summary so that I can take a look and compare what they're being offered in retirement or on their current plan that they are maybe paying some or a lot for to see how it compares to Medicare based on their health and their budget. But really to look at the premium costs as an employee and the spouse. Maybe a child's on the plan as well until they aren't. And are there substantial savings? And that's really an important part of what myself and my team does, because we're really looking at the current utilization of people's healthcare. Um, they have copays, they have deductibles, and they have out-of-pocket maximums. And many people aren't familiar with those because they haven't necessarily used them. But it's important to compare what they could have to what Medicare offers, and again, the cost associated with it. But the transition to retirement is really a big impact for people, whether they want to go into Medicare or they feel like it's the better plan for them. That retirement component is when people reach out. They reach out 3 to 6 months before they turn 65, 3 to 6 months before they retire. And I say 3 months before you move as well, because certain states have different laws and rules and plans. Some even by county. But each year, this time of the year, to evaluate the coverage to ensure really that it's the best fit for your current budget and health. That's what this season is about. But is Medicare automatic? I mean, many of you are on Medicare already, but for those who are not and you're approaching Medicare age, if you are collecting Social Security at 65, you are going to get Part A and Part B automatically. Now, you can decline Part B and not pay that premium, but depending on the size of the company that you work for, greater than 20 employees, then you don't necessarily need to get A or B. But people do. People get Part A because they feel like they have to. There is never a penalty for not getting Part A. Again, over 20 employees. But if you reject your Part B and you're collecting Social Security, you'll get a new card that has just Part A on it. And you'll use it if you need it, but most people actually don't wind up using it and just use their company coverage. But if you're not collecting Social Security at 65, you need to be proactive. You need to sign up when you're getting ready to retire. And again, if you're self-employed, unemployed, or working for a company of less than 20 employees, you must get Medicare at age 65. So it's not necessarily automatic. But original Medicare, which is what people think of when they often think about Medicare, it's just A and B. That's it. So Part A, often premium free for most of the people we work with if they've worked 40 quarters or 10 years and their spouse as well, either one. But it includes the inpatient hospital care, some of the skilled nursing, hospice. That's Part A. Part B, on the other hand, is all the doctors, all of the specialists, all of the x-rays, diagnostic, durable medical equipment, preventative exams, all of that is Part B, and there's a premium for that, and I'll talk about that in a moment. Generally, this is 80% coverage and does not include drug coverage. So that's original Medicare. But original Medicare doesn't cover everything, to many people's surprise. It doesn't include the dental. It doesn't include things like acupuncture and hearing aids and adult daycare. Skilled nursing is very different between Advantage plans and Medigap plans, but these are things that some of the Advantage plans do offer, which is why people are enticed or interested in these Advantage plans. But original Medicare and a Medigap plan does not cover these items. The enrollment periods, we're in one right now, but the one that people often think about is that 7 month window. That's the 3 months before the month of your birthday, the month of your birthday, and 3 months after. The only people that have to pay attention to this are those people who are unemployed, self-employed, or working for a company of less than 20 employees. Other than that, you can wait until you are ready to go into Medicare and you have a special enrollment. Annual enrollment period is right now. For those of you who are on Medicare, I'm going to continue to encourage you to review your plans, make decisions. We'll talk about a lot more about the changes going on. But October 15th to December 7th is that period of time that the review of plans are most important. The open enrollment period is January through March. It's not an often talked about period of time, but people can change their Med Advantage plan to another Advantage plan, or they can change their Advantage plan to original Medicare plus a prescription drug plan. So that's a unique period of time that people often, especially the ones that we work with who come from us from medical offices in the area, are often able to make the change if they're disappointed with the coverage in which they signed up for initially. The special enrollment period, this is those people who are losing their employer coverage. They're 68 years old, they're ready to retire, happens all the time. They have a special enrollment any time of the year. So they are able to sort of plan this. Maybe it's 2 weeks, maybe it's 2 months or more, where they know when their coverage ends. And they're able to get onto Medicare without any gap in coverage. But there are also other special enrollments moving out of the state or the county. And then there's FEMA related, there's hurricanes, fires, all kinds of FEMA related activities that the carriers as well as the government allows there to be a special enrollment for people to make a change. So this is the income adjustment. For those people who are higher income earners in the years before they actually go into Medicare, they need to pay higher than the average person who is making less than 2 years prior. So you can see from this chart that, and this is the new chart for 2026. So an individual, $109,000 or less, a married couple, $218,000 or less. This is the federal tax return, line 11, adjusted gross income. So that Part B premium went up as well. That Part B premium went up from $185 a month to $206.50. Again, another 11% increase. You can see that the brackets beyond that are tight brackets, and the premium goes up fairly swiftly. And there's also a Part D adjustment that goes along with your prescription drug plan. And you need to have a prescription drug plan, or else you could face a penalty, and you really don't want to pay retail pricing. But this is the chart, but there is good news. The good news is that there's a life-changing event form. This life-changing event form we have helped hundreds of people with where their income has dropped after they've retired. And this is really just an estimate of the current year's income. Now, if people retired at the end of September, they have the fourth quarter of less income, and or going into 2026, their income might drop yet again, and they can fill out this form and they can reduce the bracket, even if it's one bracket. They can reduce it and save on the Part B and the Part D income adjustment. So to keep it simple, there's four options. There's the employer group plan and retiree plan. People can stay on it. People can decide if that's the best plan, looking at the benefit summary, reviewing the copays, deductibles, and coinsurance, looking at who else is on the plan. That's an option, and I will always opt to suggest staying on it if it's close or similar because you may not get that employer or retiree plan back. So I do a lot of review of benefits from employers and retirees. Original Medicare, as I mentioned, 80% covered by Medicare, 20% is your responsibility with no maximum out of pocket and no Part D prescription drug plan for just original Medicare. So one should and would add that. The Advantage plans, I'll talk a little bit more about them later, but PPOs and HMOs are the big distinction between what's going on in this industry. HMOs 15, 20 years ago, sort of people wanted to go outside the network. And so they created PPOs. So PPOs, you can go outside the network. You may pay a little bit higher copay, but you can go outside the network. PPOs have been very much utilized over many years, and that's changing a little bit. But these Med Advantage plans have a little dental, not a lot, a little vision, a little gym membership, sometimes a little hearing, sometimes a little over the counter. Some of those things that original Medicare doesn't cover are put into these plans. Again, and people like them a lot, but the premiums are very low. You can get a Med Advantage plan in 70% of this country for zero premium. You can pay $40 for a premium, but they're low premium compared to these supplemental plans in number 4. The supplemental plans in number 4, these are the best plans in America because you can go to any doctor you want anywhere in the country that takes Medicare. So people like this for peace of mind. They travel a lot. They don't want to work with the Advantage model. Their concern on the Advantage model is some potential extra denials or advocating for some services that might be needed, but these are much more expensive. These premiums have gone up as well, and it does not include a prescription drug plan. So one needs to add the prescription drug plan. A lot of you on the call certainly are familiar with this model and have made decisions, but this is the year to evaluate it. So when we do an Advantage plan and somebody is either on the fence or knows they want to go on the Advantage plan, maybe for price considerations or they don't have any chronic conditions, we take a look at all the doctors that you have and we look at multiple carriers and we say, okay, this was in network and not, and we document this. This is important work. We have staff that just does this. We go directly to the carrier's portal. If we don't get the answers we think we should be getting, we will actually call the practice themselves and see if they take certain carriers. So we do the work, but these things change every year. So a carrier may not have the same doctors in their network the same next year. I would say most of them stay, but it's not necessarily true that it's a guarantee that in the following year that they will all be in the same network on your plan that you have. So these are some Advantage trends. And this is important because it's surpassed 50% in this country. So 54% of beneficiaries, that's 34 million people, are in Med Advantage plans right now. And it's growing slightly now after years of really rapid expansion. So the numbers are high, and comparing to original Medicare, it is higher than original Medicare. But Medicare spends 20% more per person actually on these Advantage plans than in traditional Medicare. So there's a cost issue here. And so there's a big cost for the government. The government actually pays the carrier for every person who's on the plan. Depending on the state, the county that one's in, they actually pay a monthly cost to each carrier to manage your care. So profitability is absolutely an issue. So these are the leading Advantage companies in 2026. United Healthcare leads with 29% of total enrollment, adding about 500,000 new members this year. Humana follows by 17%, but their enrollment dropped about 300,000 in 2025. But together, United Healthcare and Humana cover nearly half of all the Med Advantage enrollees nationwide. But of course, there's other carriers. There's Aetna, there's Anthem, there's Kaiser Permanente. There are other carriers out there, but this is just some information on Advantage plans. Prescription drug plans, the single biggest area that we deal with all year long. The Inflation Reduction Act, which really, from many perspectives, it's not the headline grabbing um, topic like the big bill that came out with the current administration. This Inflation Reduction Act has been subtle, but has had major impact on the Medicare industry. And I say that having seen the last year, now the second year, and again, could take 3 years for this industry to reset. The annual deductible on these plans are up to $615 for 2026. That's only on brand named medications. On generics, that does not apply. There's no more donut hole. In 2024, the maximum out of pocket for anyone was $8,000. In 2025, it went down to $2,000. 2026 is up to $2,100. But that's the maximum out of pocket for Medicare approved medications. That is an absolute game changer that has caused a massive reset to the industry. And I speak about this every time I can, because when we look at the next handful of slides and we look at the impact of this, it's because of this that all the carriers have had to adjust their pricing and their benefits. But these prices change yearly. Big premium increases this year. There are some carriers that have raised their standalone prescription drug cost by $50 a month. There's preferred pharmacies, there's standard pharmacies, and then there's mail order. But one needs to have a prescription drug plan. One shouldn't pay retail, but these prescription drug plans are expensive. So if you look at the various resources that are out there, some of you are familiar with GoodRx. There's a Florida-based company called Canadian Store. Cost Plus. Today it was announced that Cost Plus and Mark Cuban joined Trump RX, Drug Pricing Transparency Initiative. So, that's really going to potentially change a lot. So the goal in this Trump RX is to have a direct to consumer online platform where Americans can buy discounted medications. Eli Lilly, Bristol Myers Squibb, these companies are all in line to negotiate their prices. But what's also happening is because of the tariffs, prices are being raised across the world. So Eli Lilly has raised their prices in the UK, as well as Bristol Myers has raised their prices in the UK. So, it's true, and I think all of you have a sense of this, that Americans pay about 3 times more for medications than comparable companies. So there's a really large emphasis. And again, it's about the reset. This year is going to be painful. And I'm going to tell you honestly, folks, it's painful for you and for us. A lot of the carriers have opted to no longer pay brokers and agencies anything for helping people with their prescription drug plans. But we do it anyway because we care. We also have a lot of your medications already in our system, and we have become smarter. We've leveraged efficiencies and technologies. So this prescription drug component is really important. And I believe that the pushback on some of this will be quite significant, possibly as we get into January. But some of the price increases that are already being seen from people for certain carriers where notifications have gone out with price increases that are equal to $50 a month. We are doing our best to contact everybody because that is what we need to do to help them change to another plan. So when it comes to the prescription drug costs, if you look at this chart, you'll see the impact for the member, a carrier, in this case, UnitedHealthcare, CMS, which is the Center for Medicare and Medicaid Services, and the brand manufacturer. You could see what the impact was pre-Inflation Reduction Act and post-Inflation Reduction Act. So the member is now paying only 5%, and the carriers are paying more. CMS is paying more, um, and the brand manufacturers are paying less. So that is just a very large impact, and it's just causing all of the impact on this industry that we're going to keep talking about. So I'm going to talk just a moment about dental and then get back to some other important pieces. People say that they want dental, but they don't use it. A lot of the carriers have offered dental. The Med Advantage carriers have offered dental, and it's amazing to me how few people use it. So they still offer it, but they've certainly cut back on it. A lot of people ask about dental. 80% of the people really do ask about it. Some people are able to stay with their current plan from their employer. We help people, Carrie specifically on our team helps people find dental plans that are standalone plans. But we often ask you to ask your dentist, what coverages do they like? Sometimes they'll offer a discount plan, but people don't actually go to the dentist because of the costs. But if you look at this chart, you see that on the left side, especially the preventative, those are usually free. And it is on Advantage plans as well. The basic services may be free, but often 20% out of your pocket. On the other hand, the major services, the comprehensive services, are usually at 50%. When people say to me that their coverage isn't good, it's really often that they're not fully understanding the dental coverage that they have. Because 50% of $1,000 is $500 to the carrier that they're paying and $500 out of your pocket. But it's still coverage and it still helps. Some of the carriers have riders on their plans where you can get $1,500 to $2,000 worth of coverage. Very few carriers, even standalone carriers, cover implants. But this is a needed benefit. And some people really want it, but it's not necessarily meeting their expectations. Hearing aids as well. Again, if you look at the expense of hearing aids, everyone knows they're expensive. The ones that are over the counter are not necessarily as good. We really encourage people to go to an audiologist. The technology and the testing that's available for hearing aids is incredible these days. But there's a real stigma around hearing aids from millennials, from Gen X to boomers. People wear glasses, they wear contacts, they use an Invisalign, but hearing aids really just simply need to be seen as normal. On the other hand, there's serious health issues relating to hearing. And it increases loneliness, isolation, depression, heart disease, and even stroke. The risk of falls, which I and many others are concerned about, increases by about 50% if there's a hearing loss of some sort. But social engagement is really important for people as they get older or they're alone. So it's really sometimes people are just not paying attention to this component, and or they're not investing in good hearing technology that lasts easily 10 years, but they are expensive. There is a program that's new. This is a part of a larger pilot program called Guide. And this is for those folks who are have dementia. And this is a plan that there are 300 approved guide providers in the country. There's about 30 in New York State. And they provide the things listed on the bottom there. It's really for people living with dementia and their caregivers. It's comprehensive assessment. It's caregiver support. It's respite, so people get a break from this caregiving. But it's coordination. It's coordination so that the clinical and support service, the transportation, the meals are all being handled and handled effectively. And then it's 24 access to a team. It takes a lot to get approved for this program, and it's a pilot that's working well. So back to drugs for a moment. These on the right, these are the drugs that have been negotiated for 2026. So you can see some common medications that are out there. Many of you may be familiar with them, and the discount is significant in many cases. It's still high. And again, keep in mind that there's a $2,100 maximum out of pocket. And so certainly Eliquis is a big one, Xarelto is a big one, and there's others that are on there that are important. On the left side, you see that these are drugs that are slated to be included in the next negotiation cycle. With all the things going on with Trump RX and Mark Cuban, the industry is trying to figure this out to help the average consumer lower their drug costs. But to the extent that the insurance companies have an impact, it changes other premiums and other benefits. So one of the big changes, folks, that I need to share importantly is that these PPO offerings that I have mentioned before, which has been a real popular offering for many, many years now, are being reduced and in many cases eliminated. They're just higher maintenance costs because a PPO essentially means you can go outside the network. The goal is for these organizations, these hospital facilities, to control their costs, to be more efficient and profitable. It's easier to control the costs for the insurer and offer more benefits. So the HMO plans are offering more dental, they're offering more vision, they're offering more benefits because they can control the costs on all areas of the healthcare. There are big impact to this. And it's really surprising to many people. It's a reversal of what has been a PPO marketplace that has certainly grown steadily over the years. It's become very popular. But now there's a provider network, and there's just fewer PPOs in 2026, and PPOs will likely carry higher premiums, and over time they could be eliminated. And there are plans right now that are being eliminated, and they're having what's called crosswalked, meaning that if people actually don't pay attention to what they are actually seeing in what's called their annual notice of change document that's sent to them, they will potentially be crosswalked onto another plan that's similar that the carrier is sharing with you. And unless you opt out, that's the new plan that you're on. We are working like the Dickens to be in touch with all of our clients, to inform them, to encourage them to reach out. We have a large list of people we're already supporting. We're looking for people to fill out what's called a scope of appointment so that we actually can officially work with them. We're actually them to go online and actually enter doctors and meds online through what's called a personalized URL. And we're doing everything we can, again, as a company to help more people and to work smarter. But this HMO PPO piece is really creating a lot of change. So if you are looking at the HMO versus the PPO, you need to ask yourself, do I want to keep my current doctors and specialists? Are they all in the network with the HMO option? That's the work that we do. Would I rather pay a bit more each month for that freedom to see providers outside of my network? And how much do I rely on the extra benefits like dental and vision and over-the-counter, gym, et cetera, as you know, to get that PPO versus the HMO? So there's no one size fits all for all of you folks on the call. The right plan is the one that best aligns with your health, your priorities, your budget, your health, and the comfort level. But these plans vary by county. And again, PPOs are slowly leaving the marketplace. There are actually new plans on the marketplace. They're called CSNP, Chronic Condition Special Needs. This is a special type of Advantage plan that, yes, it includes prescription drug coverage, but it also has care coordination, which I talked about in the guide program, for certain illnesses only. So they connect you with a team of doctors, nurses, who really have the ability to create a personalized plan to manage your condition. The conditions that I listed here are conditions that are currently on the list of a few different carriers. Not all of the carriers have the same diseases, but not everyone qualifies. So it still has the $2,100 cap. There are certainly lower prices for higher cost medications. And there are some rules for them. There's the supplemental benefits. You can't buy alcohol, tobacco, or non-healthy food items. But these are just the extra perks that are offered on the CSNP plan. This is brand new. It's been offered lightly in previous years in certain states, and in most cases, brokers were not allowed to sell it. You had to go directly to the carrier. They're now allowing us to offer this in the circumstances that apply. Med supplement increases. Again, another big surprise for people. Some of you on this call have probably received information about price increases for the various carriers that you may be on. New York has fewer carriers than New Jersey, and other states have more carriers offering med supplements. But these premiums are increasing more than ever before due to healthcare costs and usage trends, right? So Plan G, Plan F, high deductible plan, these and the carriers are just asking more health questions. And so if one is switching from one not in New York and not in Connecticut, not in Massachusetts or Maine, but in the 46 states that are not those, the carriers will ask you health questions if you are switching from one carrier to the other. And that's important because if they're starting to ask more questions, that means they get to deny a change of plan. So that's why when people are coming on to Medicare and deciding on a supplement versus Med Advantage, they need to think long term. They need to look at their long-term budget and long-term health, though they don't know it. They want to make some kind of predictions on what they can reasonably afford. But there are different pricing models across the country. There's community rated, and there's age attained and issue age. So prices in community rated, they go up. A man or a woman, it goes up at the same time, has nothing to do with age. And the rates generally in that case increase once a year. Age attained and issue age, we know if you crossed another year of your birthday, that's an attained age. Issue age is when you actually got the policy issued. Some states have one or the other, and some have both. So depending on the state, you can actually see two price increases. In New York and Connecticut and Massachusetts, it's community rated, but the premiums are much higher. They're higher, and it's because they actually never have underwriting. So those states without underwriting have more expensive premiums because they actually accept people that are not as healthy. In those other states, somebody applies, they ask health questions, they don't qualify, they have to stick with the plan or the carrier that they're on. So, the questions are important. Different carriers ask different questions. So the premium can change based on your age, your state, your birth date, your enrollment date, your carrier's loss ratio, and because they have to submit to each state's Department of Insurance for price increases. Usually people get a letter saying this is what we project to be the new rate, and then a month or two later, it becomes final through some approval process at the Department of Insurance. They actually submit for increases somewhere around the beginning of the second quarter of the year. So that's what happens. But what's happening now is new, lesser known carriers are entering this marketplace. It's expanding competition, folks, and it's good and can offer better pricing. So these are some carriers that you know and don't know. The ones above the line, you probably know all of them. And these are the ones who do a lot of marketing, and they have probably higher price increases these days than others. But they're known, and people like a known entity. Many of these carriers over the decades of med supplement carriers have had price increases of a reasonable 4 to 6%. Now the increases are between 10 and 30% nationally. So these carriers that are on the bottom are on our radar because they're coming in with low pricing. And again, based on what state you're in, they may or may not be available. And depending on your health, you may or may not qualify. But this is what's being offered. This is what we need to do as a company and what we need to offer. So I say bear with us, but I mean that this change of carrier preferences is occurring right now as we speak going forward. So you need to consider alternative options. So for those people who are seeing huge price increases in some of the states that you're listening to me from, some people are looking at Advantage plans. And the reason they're looking at it is because in certain states, you can actually switch down the road without any health questions. But in those states that there is underwriting, that's a risk. But that is one opportunity. There is also what's called a high deductible Medigap plan. I'll talk more about it in just a moment. But again, back to the underwriting. There's no underwriting in those 4 states. Approval is not guaranteed. But many clients find that their current plan is still the best. They can afford it. They have it in their financial plan, and they don't. It doesn't always mean they're going to switch. And the price increases are unknown for the future. So some of these carriers can come in low and then raise their premiums 10 to 30% in subsequent years. There's no way of knowing. So it's a tough decision to make. But there is something called the high deductible plan. And these are becoming more and more popular. People have, some of the people on this call probably do have them, but they're lower monthly premiums. Substantial savings on the premium side, but the deductible in 2026 is a little over $3,000. Once you meet it, you have the same benefits as Plan G, meaning that you have no other costs. This is high deductible G plan. There are multiple carriers. I'm just going to read off a few of the carriers: Globe, Humana, Emblem, Banker, Cigna, Mutual of Omaha, Connecticut. Depending on the state, various high deductible carriers exist. But it gives you the same nationwide flexibility that any Medigap plan offers. Again, depending on the state or the carrier, the premiums vary. They could be $50, they could be $95, but you have a $3,000 annual deductible. So, a healthy individual without frequent utilization. But one of the pushbacks that I get on these plans is they're getting 20% bills for everything. So if you have $1,000 charge for a service, government pays 800, you pay 200. Another charge 500, you pay 400. Excuse me, the government pays 400, you pay 100 until you get to the $3,000 figure, and then there's no other costs. So it's just something to look at as an option. This is a chart that I put together that I thought would be helpful. This happens to be New York, so the prices are high and the math doesn't necessarily work for all of you. But if you're looking at a monthly premium for going into 2026 of $297.50, and you multiply that on an annual premium plus a prescription drug plan, you're talking about a $4,000 cost. If you're talking about a high deductible, it's not final. I think the price will be about $91 in New York for at least one carrier that I know of. You multiply that by 12, right? And then you get a lower number, but then you have the $3,000. So you get to almost the same figure if you're maxing out the high deductible plan. Again, in certain states, if you want to switch from this high deductible plan to another plan, that's Plan N and Plan G, you would have to go through underwriting. In New York, Connecticut, Massachusetts, and Maine, you do not. Another thing that I wanted to share with you, which I think is important just to understand, is this 3 midnight rule. So skilled nursing, you must spend 3 consecutive midnights as a hospital inpatient for you to get skilled nursing facilities covered. Now, this is not including observation. Day one starts at midnight after you're admitted, and the discharge day doesn't count. Example, Monday, stay through Wednesday night, discharged. Thursday, you disqualify. So why observation and leaving status matters? A common point of confusion is the difference between being admitted and under observation. Many of you have heard of this. Even if you stay overnight or longer, observation status considered outpatient care. Unfortunately, that time just doesn't count towards the 3-day inpatient requirement. So before you leave the hospital, you need to ask a simple but critical question. Was I officially admitted as an inpatient? The hospital staff can truly verify that status to see if you qualify for skilled nursing facility coverage. But what should you actually do before leaving the hospital? Confirm your admission status. Make sure you were an inpatient, not observation. And you can ask that pretty quickly, actually. Talk to the team at the hospital. See if there are any waiver programs. Contact your Medicare plan. Confirm your coverage and potential exceptions before discharge. So I thought that was an important piece to talk about. So when it comes to hospital stays, one of the things I want to talk about is on the bottom is the days 1 through 6 and day 7 and beyond. So depending on the Advantage plan that one is on, you could be spending $300 to $400 a day. As we know, hospitals are looking to get you out of there quickly. And usually 7 and beyond or 7 through 90 days is no cost. So those first 4, 5, 6, 7 days, depending on the insurance company, could be, I've seen as low as $250 and as high as almost $500 per day. So this is one area that people often don't pay attention to in terms of the hospital stay and the cost that exists. So here we are in open enrollment. And this is a very, very interesting time of the year. People are concerned about the future of healthcare. The truth is that for every dollar that's collected for premium or co-insurance, the government or the insurance companies are paying out $4 in claims. So I know that people are anxious about the industry and where it's going. I know that clients of ours and prospects and advisors and social workers know that this is a vulnerable time. But our goal in working with you is really to demonstrate the value that we have as being your trusted partner. In a way, we are the glue that holds this all together. One of the things that I did want to mention is that in the prescription drug market, there is what's called a payment plan. And this is new. And if someone is paying $2,100 for the year, but the first month they are coming out of pocket for almost the entire thing because their medication is so expensive, they can actually go onto a payment plan and they can spread it out over 12 months. This was offered in 2025. Only 6% of Americans actually use the payment plan option, but it is available. And they really can't send you to collections. So that's an important thing to mention. So we know that the annual notice of change was possibly received in your mailboxes or online. And they were sent out in September, and it really did detail any changes to your current Medicare plan. They are obligated to send the change, even if there's only one change. But as you heard from this webinar, there's a lot of changes that are going on. It's crucial to review and compare. We are busy nonstop. The phone is ringing. Again, we added 2 wonderful new resources to our team, but we need to help you decide whether this plan that you're on suits your health needs and financial situation. It may very well be you stay the course and you may not be happy with the answers and the plans that are being offered. Um, and it will reset in a few years. But going forward, it's important to compare it, to work with an independent advisor who's looking out after your best interest. Our services are no cost. So whether you're a Medicare recipient, financial planner, CPA, case manager, or social worker, or any other professional, um, know that this is the time of the year to reach out to your clients and really offer your help to them. So the Part B premium is going up to 206.50, 11% increase. Part B deductible going up 11% to 288. Um, the maximum out of pocket actually went down just a little bit, but it's really hard for anyone to get to that number. Based on the amount of money it costs for a hospital stay or surgery. Um, and my comment is $1,000 to $2,000 for a hospital stay. Um, but to get to $9,000, one has to be, dealing with some serious issues, and that's the maximum. The Part D deductible is $615, up from $590. So it's important for you to recognize the importance of just knowing your plan's potential costs. You don't have a crystal ball, but you know what the potential costs are. One of the other things that has changed is that the carriers have moved from a copay to a co-insurance. So if the copay was $150 for an MRI, and now it's 20%, which is higher? Well, it depends on the procedure. And in most cases, the 20% is higher. So that's happening with prescription drug plans. It's happening with regular plans as well, is that co-insurance is becoming the norm as opposed to a set dollar amount. But there's a big integration between healthcare costs and financial planning. Working with so many wonderful financial planners and CPAs, I know how important they think that this is and the work that we do to support their clients. But I can't emphasize enough the importance of advocating and appealing as needed, whether it's the services that are being rendered or the prescription drugs that are not being approved. Advocate, have someone advocate with you for you, appeal it. Don't just pay the first bill that you get. Sometimes it just needs to go through the cycle of Medicare and the secondary. And so advocate and appeal is really just a big part of what the industry needs to continue to do for themselves. Seek objective information. Look for a trusted Medicare resource. We feel like we're very special, very unique. I'm proud to lead the team that I do. They're the best, and we will continue to add to our staff and increase our level of service as best we can. But this is the open enrollment season where changes are being made, discussions are being had, doctors and meds are being sent to us, and we're getting back to people as quickly as we can to be able to help them make this decision. But people who are not on Medicare or approaching retirement, they need to look at those decisions and call ahead of time so that we can guide them properly because people are so anxious about these issues. I am just always shocked to hear how incredibly concerned they are. But I will say that I do believe that with the big bill that's come out, and let me just speak for a few moments on that. And I don't like to get too engaged with it, but that bill that has come out is impacting Medicaid. But the impact on Medicaid has downstream impact on Medicare. The reason is that about 30% of rural hospitals are likely to close because of the lack of Medicaid payments. In addition, the people who are on under 65 market for the Affordable Care Act, the subsidies are likely to be reduced. Hospitals and facilities are having to make adjustments right now to make the adjustments necessary for when the bill actually takes place and the Medicaid impact is there. but we know that the government is in a shutdown mode. And the big issue, probably the biggest issue and the only issue left, is the subsidies and Medicaid. And that's not going to be easy to be resolved. There's a tremendous number of people who are going to be impacted. Prices will go up on premiums and benefits will go down. This, all the things that I talked about here today is before the bill is impacting us. This is just because of the Inflation Reduction Act. This is going to pile on to the changes, the impact on the average consumer. There is no way that it won't impact everybody. Um, Retirement programs, group coverages are going up. The premiums are going up at a staggering rate. Um, and insurance companies can only absorb so much. So there's a really big impact to that based on the bill. And so people have to just know that if we can get past the time frame that we're in and move forward and get the government going again, the way politicians handle the future of healthcare, I believe, is going to be a key component of the way in which the next handful of years go on. But when it comes to doctors and medications, it's all about you. You are the consumer. You want to know your doctors are covered and your medications are covered. And that's what's important to you. You want to know costs too. And all those things are all connected. The Advantage plan and the Medigap plans, I spoke about them at length. There are changes, there's impact on that in a very, very significant way. Medicare and Medicaid eligibility is going to change. But, tell a friend, tell your CPA or financial planner, post a nice Google review about our company. A lot of you know us well. You know the services that we provide. This is our wonderful team of 7. I am so proud of all of them. They've done such great work. The 2 on the left are the newest team members. Linda on the left, Chris just to the right of her, and then you see me. And then to the right of me is Kerry, Michelle, Diane, and Matt Civitano. So with all of that said, folks, we try harder every day. My goal is to inform you. I'm doing another webinar on the 30th that will be very similar. Don't know that I'll have a lot of new information at that time, but it will be very similar. This webinar will be recorded to be able to be listened to. Call with your questions. I don't know how many folks have communicated to Diane and Kerry in the chat, but again, I'll keep them on for a little while and then we'll log off. This is our phone number. We cover 31 states. We've got over 3,000 clients. We're proud of what we do. And the last thing I'm going to say is I love speaking about this topic. I'm speaking tomorrow up in Albany, New York. I've been in Philly and Texas and Chicago and LA. So if you have a church or a group or a financial planning office or anyone that you want to bring me into to educate people who are turning 65 and retiring, please let me and my team know. So I want to thank you all from the bottom of my heart and from all of the efforts from our team to help make our way through together this open enrollment season. I wish you all the best, and I thank you for your attention to this webinar. Have a great day, and thank you.